Assalamualaikum and very good morning. Thank you, Prof. Zulkarnain. So I'm Rozita from Clinical Oncology Unit, a clinical oncologist. And just a short introduction, with me is Dr. Wong Quan. He's a final year clinical oncology trainee. So he will enlighten us on one of the common side effects of radiation therapy, that is radiation dermatitis. Without further ado, I will pass this mic to Dr. Wong for his presentation. Thank you.
Right. Good morning, everyone. Today I'll be sharing on radiation dermatitis. So, first of all, what is radiation? Radiation is basically the transfer of energy in the form of waves or particles. So, this is everywhere around us, and we are unable to avoid it. Some of the radiation may come in the form of ionizing radiation, and this is also all around us in the environment. So radiotherapy is the use of ionizing radiation to treat cancer and also other diseases. And the most common form of radiation that we use for treatment or radiotherapy are X-rays. So ionizing radiation can cause damage in tissues, and basically it treats cancer by killing off cancer cells. And surrounding cancer cells, we have normal tissues, and these normal tissues are also affected by the radiation. So radiation dermatitis is common. It can occur in up to 90% of patients treated with radiation, and it can range from mild to severe. What happens is that the basal cell layer of the skin is disrupted by radiation, and this prevents the cell regrowth, and the regeneration properties of the skin is inhibited. So at the same time, their immune cells from the surrounding area will migrate and move to the site of injury, and this causes inflammation. So radiation dermatitis can be divided into early as well as late reactions. Early reactions occur within 3 months of treatment, and late reactions can occur later at months to years after treatment. So some of the acute side effects that patients may experience is redness, swelling, itch, or pain at the site of radiation. And radiation effects are usually focal, so it's directed to the site where the radiation is received, and it generally does not affect other parts of the body. At higher doses, it can lead to wound breakdown, ulceration, and sometimes there can be superimposed skin infection. At areas where there are hair or glands, there can be temporary alopecia. So as for the late effects, there can be permanent alopecia, which is a loss of hair, skin induration or hardening or thickening of the skin, delayed ulceration and necrosis, fibrosis and scarring, telangiectasia, which is development of small blood cells at the site, at the skin. And these effects can happen at doses of above 45 grays. In addition to that, regardless of the dose, there is an increased risk of secondary cutaneous malignancy, more commonly squamous cell CA or basal cell CA. So here I have some photos of side effects from radiation to the skin. So on the top left here, we have some small vessels that we can see sprouting, which is actually telangiectasia. Surrounding that, we can see that the skin is dry, flaky, and scaly, and there is also dark areas which are hyperpigmentation. On the right top corner here, we have a band-like area of hair loss. So this correlates to the site where the radiation was delivered. So the hair follicles or the hair cells at this area is disrupted, and that leads to this picture of hair loss, which is a very straight line. At the left bottom corner, we have a picture of an ulceration, which is surrounded by fibrotic skin. And the right bottom here, we have a basal cell CA change on the skin of a patient. So these are some of the things that we can notice in our patients who have underwent radiotherapy. Of course, there are also many patients who may not complain of any side effects because it might be mild, where there's a slight pain, a little bit of swelling or mild redness, which may not be noticeable unless we actually ask the patient. Right. What are the risk factors for developing radiation dermatitis? That depends on many things, among them the site of radiation. So some areas where there are skin folds or extremities, the risk increases. And factors related to wound healing, patients who smoke or are obese, have poor nutrition, or have diabetes, they are at higher risk of getting radiation dermatitis. So of course, the dose and the dose per fraction, cumulative dose and dose per fraction will also affect the risk or likelihood of getting radiation dermatitis. Use of bolus, which is applying a layer of wax over the skin to increase the skin dose, will definitely increase the risk of getting skin reaction or radiation dermatitis. The use of this bolus is to ensure that tissues, cancer that have affected the skin layer or skin cancers are treated adequately. So if the skin will receive a higher dose, definitely the risk of getting radiation dermatitis is much higher. So in certain circumstances, we actually combine radiotherapy together with systemic chemotherapy or targeted therapy like anti-EGFR to enhance the efficacy of radiotherapy. And the concurrent use of these agents can actually increase the risk of developing radiation dermatitis as well. So how do we prepare our patients, or what advice do we give them to prevent radiation dermatitis? So we tell them to avoid irritation or friction to the treated site during and after radiotherapy. And this should continue all the way until their skin has recovered. And they are advised to keep the area dry and clean, not to rub or scrub the area, but to dab dry with a towel. They should wash the area with lukewarm water, not hot or cold water, and they should not apply soap, perfumes, or alcohol rubs, or maybe baby powder to the site where radiation is being treatment is received. They should wear loose-fitting clothing. This is to prevent friction as well as to reduce sweating and make the airflow and circulation better. They should also avoid sun exposure, excessive sun exposure. And if they have to go out into the sun, they should use sunblock. Shaving can actually cause the skin reaction to be happen more quickly and acutely, so it should be avoided where possible. And they are encouraged to use water-based moisturizers to protect the skin, to keep it moist. And the use of low-potency steroid cream and silicone dressing can actually help with providing a protective barrier for the skin. So we grade adverse events according to CTCAE, and it's graded between 1 to 5. 1 is erythema and hyperpigmentation. This can occur at doses of more than 12 grays. Grade 2, which is a dry, fine desquamation, can occur at doses above 20 gray. Grade 3 occurs at more than 50 gray, leading to moist desquamation, and grade 4 leads to more severe moist desquamation and ulceration. Of course, alongside with this category of side effects, the patient can also experience other symptoms which has been described earlier. So here I have a picture of a grade 1 radiation dermatitis. You can see that the skin is pinkish, faintly red. That's grade 1. So here we have a picture of grade 2. You can see it's more angry looking. The normal shiny surface of the skin has disappeared. It appears dry. There's a flicking of the skin. And next here we have grade 3 radiation dermatitis, where you can see that there is a moist areas. There's a beginning of a development of a wound at the site. And here we have grade 4, that is more severe. There is ulceration, and basically the circumference of the area has already been affected. So of course, grade 5, we have death from radiation dermatitis. With treatment intent, this is less likely to occur. However, it can occur in situations where there is radiation accident or radiation exposure accidents. right? So how do we manage patients who have developed radiation dermatitis? So we definitely advise them to continue with the general skin care if they have not already done so. And sometimes even though they have received the advice, they may not have apply the advice as instructed. And so it's good to go through with the patients and see what they understand about the skin management that they should be using. And sometimes perhaps ladies might be more familiar and more acceptable of using daily skincare. However, sometimes male patients might find it uncomfortable or less acceptable to them. So it's good to encourage them to be able to continue using the skincare products like the moisturizer and the steroid creams. So if there's any signs of infection, it should be treated. It could be fungal or bacterial infection, which requires appropriate treatment. The use of silicone-based dressings can help with moist desquamation by protecting the skin and providing a barrier. So if the patient has developed a grade 3 skin reaction, they may need to interrupt the radiotherapy session to allow them to rest. If the treatment is being given concurrently with other treatments like chemotherapy or targeted therapy, those could be withheld to allow the radiotherapy to continue. But if it is not responding, then radiotherapy may have to stop as well. So if the patient develop a grade 4 skin reaction, this requires a multidisciplinary management with other teams, including the dermatologist and plastic surgeon. We need to stop the radiation therapy at this point in time to allow the skin to heal properly. The patient may need surgical intervention. They may need to have a debridement of ulcer or the wound, and they may need to have a graft or flaps being placed to protect the skin. Right. So the other thing that is difficult to manage could be chronic radiation dermatitis. So it depends on what kind of reaction the patient had. Some patients may have induration, fibrosis, and scarring, and this can be disfiguring, and it can limit a range of movements, especially if it occurs at joints. So stretching, exercise can help to reduce contractures, help them improve their range of mobility. Some other patients may find the cosmetic effects very difficult to accept. This may include things like hyperpigmentation of the skin, induration. This has been laser therapy has been tried, but its effectiveness varies. Other situations are like alopecia. Things that can be tried hair transplants. Yeah. So I end my presentation here. These are the resources that I have used in preparing my slides. Thank you.
Right. Thank you very much, Dr. Wong. Okay. We have one question for you. By Prof. Kusara. She asked, isn't the dermatitis due to the dose of radiation and prevented by giving a smaller dose, perhaps lower dose but more sessions? And does the smaller dose reduce the efficacy?
Sorry, can you repeat that? I couldn't catch it.
Oh, sorry. Isn't the dermatitis due to the dose of radiation and prevented by giving a smaller dose and perhaps lower dose but more sessions?
All right. So that has to do with the property of radiation or radiation biology and radiation physics. So generally for different cancer types, we have different dose and specified dose per fraction or the fraction size to prescribe. So in cancer, probably the more important aim is first the curative or the intent of the treatment of the radiation therapy before the cosmetic components of it. So usually we will counsel the patient of the potential side effects, and they may have to make a decision to weigh the risks and benefits. So yes, if we do use a lower dose, And if we use smaller dose per fractions and prolonging the treatment, we could reduce the risk of getting radiation dermatitis, but that may defeat the purpose of giving radiation in the first place. So, and it depends on the type of cancer. Like head and neck cancers, we may want to give to treat to 70 grays, and that definitely increases the risk of developing radiation necrosis, radiation dermatitis. That's why we see a very high rate of these problems in head and neck cancers. Whereas some other cancer sites, we may use lower dose, maybe in cancer sites of like lymphoma, we use maybe around 30 grays, and that has a lower risk of developing severe cutaneous side effects.
Okay, next question is, do we have local statistic on radiation dermatitis? Example, prevalence of grade 1, 2, and so on.
Yeah, all right. I do not have that statistic with me. I believe there have been some people who have looked into it before, but I have to look up on it. Yeah.
Okay, and lastly, what about hyperthermia? Is that protective?
Hyperthermia, is it?
Yes, hyperthermia.
Hyperthermia. Hyperthermia as in hyperthermia applied to the skin, I think. Yeah, I would say I do not have how do I say, solid evidence as in a trial that looked into that. But from our understanding, that temperature can actually potentiate the effects of radiation. It is more likely to cause worsen skin reaction and radiation dermatitis. In fact, I did have a patient who have applied heat lamp or heat therapy to the skin, and that has caused worsen. Actually, it caused radiation, not radiation, it caused a skin burn, first-degree burn. It probably related to the heat lamp rather than the radiation, actually.
Yeah, I think that's all the questions. So in summary, so this is radiation dermatitis actually is very common to happen in patients undergoing radiation in varying degrees, and it's very important to identify other risk factors apart from the radiation dose that we need to give, so that we can at least reduce the severity of the radiation dermatitis, and also to have a good education on patients that are going to be planned for radiotherapy, so that they can at least have a general skin care to prevent the severity. So okay, before that, there's one more last question. Have you observed if the skin color could affect the severity of radiation dermatitis before we end the session?
Yeah, okay, so that's an interesting question. Based on the what we know and our understanding, that there is a different presentation of skin toxicity or radiation dermatitis based on the skin color. That means in fairer people, the more noticeable hyperpigmentation and redness, whereas it also occurs in those with dark skin, but it may not be so readily observable. So the complaints will then be more of a pain, swelling in the early phase. And it takes someone to be able to observe the difference to notice it. But whether there is a radiobiological difference, I do not think so. And that is where it comes to be different from UV exposure, where UV exposure, the melatonin in the skin actually has some protective effects of from the UV radiation. But this X-rays, gamma rays, and other photon-related therapy, there is no difference in terms of the severity.
Okay, thank you, Dr. Wong. So with that, I conclude these sessions, and thank you everyone for joining the breakfast at UMHealth. Thank you.
Okay, thank you.